and loss of weight of 10 kg since 4 months. No history of TB or no history of contact of TB. No history of any abdominal pain, distension, jaundice. No history of decreased urine output. No history of any altered sensorium. He was already known case of hepatitis C, diagnosed outside on a routine evaluation, not on any treatment currently. Personal history, he is a chronic tobacco consumer with 10 pack years, chronic ethanol consumer for the past 10 years, and IV drug abuser for the past 3 years. Examination, he was conscious, cooperative, with stable vitals. He was afebrile, pallor was present. There were bilateral cervical, axillary, and inguinal lymph nodes. There was no cyanosis, clubbing, icterus, or pedal edema. Systemic examination, his chest was clear, heart sounds were normal, his abdomen, liver was palpable 1 centimeter below subcostal margin. There were no other focal neurological deficits. So summarizing, 48 years old gentleman came with a syndrome complex of loss of weight, loss of appetite with generalized lymphadenopathy. So the differentials we could thought of was malignancy, lymphoma, any unknown primary, chronic infections like disseminated TB, infective endocarditis, retroviral infections, autoimmune conditions like SLE, sarcoidosis, infectious mononucleosis, other uncommon causes, Castleman disease, Kikuchi's, angioimmunoblastic T-cell lymphoma. So on evaluation, he was found to have microcytic hypochromic anemia with HB of 11, with counts of 10,000, platelet counts of 2.48 lakhs, renal functions and electrolytes were normal. His LFT showed AG reversal with elevated proteins. His blood culture and bone marrow culture showed no growth. Bone marrow MGT expert was negative. BBVS HCV positive. On further evaluation, on serum electrophoresis showed M band with positive urine spot BJP. Beta 2 microglobulin was elevated. His bone marrow biopsy and bone marrow smear showed lymphocytes with plasmacytoid morphology with a low grade B cell NHL morphology. His kappa chain was elevated with KL ratio of more than 18.7 with elevated IgM. For a malignancy workup, we did a CT thorax abdomen which showed multiple intra-abdominal nodal mass with prominent mediastinal and supraclavicular nodes. There were no features suggestive of metastasis. We went ahead and did a CT guided biopsy. The para-aortic lymph node biopsy showed atypical lymphoid infiltrate suggestive of low-grade B-cell NHL with focal plasmacytic differentiation. On immunohistochemistry staining, CD20 BCL235 were positive, CD138 was positive, with negative staining of CD23, 10, and BCL6. So to summarize, Mr. M, 48 years old gentleman, came with constitutional symptoms with generalized lymphadenopathy. On evaluation, was found to have AG reversal with serum electrophoresis showing M band with positive BJP with elevated kappa chain. Bone marrow biopsy and lymph node, para-aortic lymph node biopsy showed low-grade B-cell NHL with focal plasmacytic differentiation. So, any diagnosis? So we came to a diagnosis of Waldenstrom's macroglobulinemia. So it is a distinct clinicopathological entity demonstrating lymphoplasmacytic lymphoma in the bone marrow with an IgM monoclonal gammopathy in the blood. Median age 64 years with male predominant 3.4 per million. Clinically, it presents due to one is physicochemical effect of the IgM and second is tissue infiltration by neoplastic cells. So the physical effects, the IgM is a pentameric molecule which stays in the intravascular, causing increased agglutination and reduction of the deformability, causing increased hyperviscosity symptoms like headache, altered sensorium, tinnitus, papilledema, blurring of vision. It usually hyperviscosity syndrome comes in a triad of epistaxis, blurring of vision, and coma. So if it infiltrates the bone marrow, it can cause anemia, thrombocytopenia, neutropenia, cause constitutional symptoms. If it infiltrates CNS, it's called Binge-Neal syndrome. It can infiltrate other organs, causing other organ dysfunction like lungs, diffuse infiltration, mass lesion, hepatosplenomegaly, lymphadenopathy. In GI, it infiltrates the lamina propria, causing further GI manifestations like diarrhea, malabsorption, protein losing enteropathy. And an entity called Schnitzler syndrome, which includes chronic urticarial rash with monoclonal IgM with constitutional symptoms. And renal failure is a very rare entity. And coming to chemical effects, it's usually the three most common chemical effects found. One is antibodies against myelin-associated glycoprotein, which will be bilateral sensory motor demyelinating neuropathy and may precede the appearance of neoplasm. When these IgM precipitates with the plasma protein, it can cause cryoglobulinemia, having clinical manifestation of purpura, Raynaud's, arthralgia, neuropathy, and can also cause cold agglutinin syndrome, causing hemolytic anemia, Raynaud's, and acrocyanosis. So usually on evaluation, these patients are found to have increased IgM specific heavy chain with a increased kappa light chain. And kappa light chain is most of the 90%, suggesting that the rest of the light chains are very rare in entity. Bone marrow findings, they will have more than 10% of lymphoplasmacytic cells with past positive Dutcher bodies. Immunophenotype, it's a plasma lymphocytic infiltration. So CD markers for lymphocytes as well as plasma will be positive uh, with light chain restriction. Imaging usually shows multiple lymphadenopathy and organomegaly. Mutations are mid 88 and CXCR4. So, Waldenstrom's macroglobulinemia, there are mimickers. There are two mimickers. One is IgM myeloma and marginal zone lymphoma. To differentiate that, Waldenstrom's will have the lytic regions are very rare with predominantly lymphocytic marker CD20 plus. However, IgM myeloma, they will have crab features, hypercalcemia, renal failure, anemia with other conditions with bone lytic lesions, which is most common, and CD138 positivity. Mid 88 is the mutation which can be used to differentiate between Waldenstrom's and IgM myeloma. In case of marginal zone lymphoma, splenomegaly and peripheral lymphnopathy is most common. However, it's a rare manifestation in Waldenstrom's. Treatment, not all. Waldenstrom's we can categorize into three groups. The treatment part, one is patients having severe anemia, hemoglobin of less than 10, platelet of less than 1 lakh with constitutional symptoms and hyperviscosity symptoms. In those cases, if there is hyperviscosity symptoms, we treat with plasmapheresis followed by BR regimen for 4 to 6 cycles. Uh, in cases of uh, symptomatic cryoglobulinemia and IgM related neuropathy with hemoglobin of less than 11 and 1 lakh 20,000 platelet, just a single agent rituximab. And in cases of IgM, MGUS and asymptomatic and hemoglobin of more than 11 and platelet of more than 1 lakh, we just observe the patient till he develops a symptoms, followed by which we start a single agent or a BR regimen based on the risk factor and the prognostication. So we prognosticate based on IPSS scoring, age, hemoglobin, platelet count, beta 2 microglobulin, monoclonal IgM. So the points highlighted was for our patient. He was stratifying in high risk category. So our patient currently is undergoing the 4 cycles of bendamustine and rituximab, preceded by a cyclophosphamide, vincristine, and prednisolone, and is planned for a rituximab maintenance dose every 3 months. So one thing I wanted to highlight is the association of NHL and other low-grade NHL and other lymphoplasma proliferative precursors with hepatitis C. So this was a retrospective cohort study done in US in between 1997 and 2004, where they compared HCV infected patients and uninfected patients, and they found out that Waldenstrom's had a was significantly associated with HCV infected cohort than HCV uninfected, and there was a threefold higher risk of Waldenstrom's and a low-grade NHL with a hepatitis C association. So this shows the same learning points. One is the association of hepatitis C and clinical manifestations, and the immunophenotypes associated with it.
You said there is reduced survival with Waldenstrom's. What's the mortality due to in general?
So based on risk factors, if it is very high grade, and if there are hyperviscosity symptoms, which is the most important one, their mortality is higher than the one which is IgM smoldering and initial MGUS IgM.
So how do these patients die?
So usually hyperviscosity symptoms involving the CNS, like headache, altered sensorium, and even cardiac manifestations, immediate coronary artery obstruction, like any vascular abnormality, obstruction due to plasma proteins.
Is it all due to hyperviscosity, or are they prone for infections?
So since it infiltrates the bone marrow, so there will be there are also only monoclonal IgM present, due to which the other infections have more propensity.
And is he still in the ward? How is he doing?
So he is in following up in hemat in OPD basis, the regimen.
Over to you. Any questions to Osborn? You have to speak up, especially the PGs. Ask something. while the presentation, you have to think about some question and you have to be ready. Otherwise, it'll be so quiet.
Hi, good
Hi,
morning.
sir.
Good morning, Dr. Ranal. Good morning. Very nice presentation of 4 cases. I don't have any comments, but just a few words. One is you had that first case of aspergillosis, rhinocerebral aspergillosis, very well done. But I would appreciate if a culture has also been done to demonstrate aspergillus, because going barely by the microscopic appearance of the aseptate hyphae, you may miss out on others. Because secondly, you also want to rule out other fungal infections also coexisting. That's one. The second one was the case from the issue of that NMDA receptor antagonist disease. Encephalopathy was the diagnosis, no doubt about it. And you have proven that it is due to a paraneoplastic syndrome, and you are awaiting the lung biopsy. I would also tend to look at it as a non-infectious condition. But you must rule out, do you have access to the entire encephalopathy panel to rule out all of these viruses and other things before we move on to the paraneoplastic syndrome? The third one was the case from Jharkhand, which was diagnosed as the case of genetically determined myopathy, because his father has also had it, and the myopathic phases was also very classic. But one or two complications that you had requested was one of the they have, if I remember correct, they have conduction defects in the heart, and you can't really do much and that is what really kills them. The second one that really kills them is aspiration pneumonia as such. And you look at him, he was very cachexic. The fourth case was also, quite instructive. And just a comment, there is no temperature called afebrile. Please record temperatures and say 98.4 or 100 or whatever it is, because that is one aspect. Yes, you did make a good diagnosis of, you went through the list. Please also include adenoids and tonsil as a part of the generalized lymphadenopathy spectrum that you examine, because they are also important. They are the, what shall I say, they are lymphoid tissues that help resist infection. So usually that is something to be examined in the mouth as such. And you made a diagnosis of Waldenstrom's macroglobulinemia, but the lymph node biopsy also shows that there is a B-cell lymphoma, and you also found HCV. I'm a little confused. What is causing the so-called Waldenstrom's macroglobulinemia? Have you done the HCV viral load to say that there can be only one etiological factor doing all of this? HCV doesn't cause B lymphoma. So what is it? Is it HCV causing the Waldenstrom's macroglobulinemia, or the lymphoma causing the Waldenstrom's? Just
Can you answer the question of what's asked?
So the viral load we did, HCV was actually very less. It was not very significantly high. So probably it's due to the NHL, B-cell NHL.